Well, welcome to everybody. We really appreciate you being here today for this All of Us Researcher Academy webinar, and we appreciate you taking the time to join with us. We have a compelling presentation and a panel discussion here today for those of you that are joining us, and we're going to have an opportunity to take a look at some of the challenges people have faced and some of the opportunities in thinking about creative ways to use all of us data. And so we'll spend some time with both a presentation and then a chance to hear from you and to hear some of your questions in conversation with some great panelists we have lined up. So before we get started with that, I do want to offer some context. My name is Brian Southwell, and I am part of the All of Us Researcher Academy. And for those of you that are less familiar with the Researcher Academy, I wanted to offer just a bit of background so that you have a sense as to how this webinar fits into a larger set of activities that we've been conducting in partnership with the All of Us program now for quite a while. So here at RTI International, we are an independent nonprofit research institute, which has been working in support of and in conjunction with NIH's All of Us program. We have a great array of people that have been working on everything from offering coaching and assistance to researchers to offering a wide variety of materials and resources for researchers who are interested in using the All of Us data set and workbench. Jennifer Uhrig has been our PI overseeing this entire effort. I do also want to note a wide array of folks here on the slide, but in particular, Sula Hood, who along with me has helped to oversee and develop the Researcher Academy. So for those of you take a step back even further from that, you may imagine many people are going to be familiar with the All of Us research program, but if you're not, we should note that this has been a historic effort to really diversify the array of data that we have available to tell the story of medicine and biology in this country. And ultimately, the hope is that by making data publicly available, that we are going to speed up discoveries and to enable new kinds of individualized healthcare. The All of Us Researcher Academy was stood up to provide training and assistance to researchers who are engaged with the All of Us Researcher Workbench. And the All of Us Researcher Workbench is the place where you can access data from all of us participants. There are a wide variety of peer-to-peer learning activities and network building activities that we engage with here in the Researcher Academy. The Researcher Workbench is a tremendous resource, as many of you in the audience today will be aware of. It's important to point out, a variety of different both types of data that are available, but also different tiers of data that are available, both in the registered tier and the controlled tier. And there are distinctions there in terms of access, the degree to which you need to be registered and looking at the types of data that are available. And we'll spend some time talking a little bit about that a little bit later today as well. I also want to point your attention for those of you that are actively engaged or interested in being engaged with the Researcher Workbench. There's a pretty robust course catalog and a set of materials that's now available for free through the All of Us Researcher Academy. And this is a place where you can look at what's been offered in the past in terms of coursework, but also what's now available to you in an asynchronous way. And there's a whole range of topics and material that you might find useful in your own journey in using the All of Us data set and engaging with the Researcher Workbench. You'll see a QR code on the screen. I'd encourage you to use that to actually access the research program and course catalog. In addition, we've also found over time a lot of people are interested in these topics, and to serve those communities, we've developed a wonderful newsletter that's available quarterly. And there are a wide number of subscribers to that. You might want to join as well. And you'll see all kinds of different opportunities related to the All of Us Researcher Workbench and the All of Us program that are highlighted. We also tell stories about researchers themselves who are doing work engaging with this type of data. There's a different QR code you'll see on the screen at the moment, and I'd encourage you to use that as a place to both access all of our newsletter issues and a way that you can get access for future issues that are going to be forthcoming. Okay, so I want to turn our attention to the main focus for today's webinar. We're really pleased to have the panel that we have here today to talk about the issue of generalizability when folks are interested in potentially producing prevalence estimates or attempting to do that using all of us data. And so we have a main presentation, and then, as I mentioned, a panel discussion. Our presenter today in the first part of this webinar is Dr. Barrett Montgomery. Barrett's a research epidemiologist at RTI International, and there he serves as project leader for the All of Us research program as a driver project leader for that, and as the head coach for the Researcher Academy. So he's had a lot of opportunity to work directly with researchers who are themselves facing various challenges and opportunities and using the workbench. And so you're going to see today that this webinar, I think, in a lot of ways springs from some of those experiences. It's also a chance for him to talk about some really important innovation that he and the team have developed. He's going to present today a framework, including an R package, that helps us and helps all of you evaluate the generalizability of prevalence estimates using all of us electronic health records. His research is relevant to this project in a lot of different ways. He focuses on socio-environmental influences on drug use and mental health, with a particular emphasis on policy. And so you'll see both that perspective informing his work, but also his technical chops and thinking about the work here. Following Barrett's presentation, we're going to have a Q&A with several panelists who contributed to the study. I do want to note Daniel Brannock, who's lead developer of the R package that's going to be talked about today, is on parental leave, but we really appreciate his contributions and wanted to acknowledge him. He won't be joining us today, but his work is evident in the work that Dr. Montgomery is going to present. We also have with us Dr. Mahmoud Elkasabi. He's a senior survey statistician at RTI International, where he's provided technical leadership in survey statistics across multiple projects. He has a particular interest in data integration and estimation using non-probability samples, and so you'll see his relevance to this work here today. In his role with the All of Us research program, Dr. Elkasabi contributed technical expertise in statistical estimation and tool development, including the design of an estimation framework and the R package to assess the generalizability of prevalence estimates. So we want to welcome him as well. And last but certainly not least, Dr. Tamara Litwin was an epidemiologist in the All of Us Research Program's Division of Medical and Scientific Research from 2020 to 2025. And so there's a lot of experience here that she's able to draw on for this panel today. She worked on participant reassessment, data linkages, survey development and implementation, and other aspects of the program's scientific agenda, data, and protocol. And prior to joining All of Us, Dr. Litwin conducted research as a National Cancer Institute Cancer Prevention Fellow. And we are really lucky to have her here with us today. She recently relocated to London, England, and was kind enough to call in today. So thank you so much, Tamara, for doing that. So before we turn to our presentation, I do want to note that we're going to be using the Q&A function here today. So I want to both alert you to that, and I'd like you to also start thinking about questions that you might have of our panelists, thinking about the experiences that they've had, but then also thinking about the topic that Barrett's going to dive into here in just a moment. You'll use the Q&A function to get us questions, and I will use that to moderate the panelist discussion once we're ready to move to that spot. So with that, I'm happy now to turn the floor over to Barrett and Dr. Montgomery. The floor is all yours.
Thank you so much, Brian. All right, good morning or good afternoon to everybody. Before I begin, I really wanted to acknowledge that this was a very large team effort, and so there are a lot of co-authors on this work. So of course we have Mahmoud and Tamara here on the call today, and of course Daniel couldn't make it because he just became a new father, so congratulations, Daniel. But we had a lot of help from folks at RTI, including Laura Marcial, Ariba Huda, and Melissa McFeeters. But this is also a collaboration with the All of Us research program. So in particular, we wanted to thank Claire Schulke, Sarah Hedden, Shandon Sastry, and Jennifer Adjemian. And certainly last but not least, Philip Greenland from Northwestern. So this was truly a collaborative effort, and we want to give a shout out to all our co-authors on this work. So first, some background, as most of you know, and as Brian did a great job of explaining, the All of Us research program is a historic effort that aims to enroll 1 million or more US participants to collect genomic, environmental, lifestyle data to enable more precise approaches to disease prevention, diagnosis, and treatment. And in order to maximize participation and optimize those insights for precision medicine, the enrollment was open to all individuals in the US, and with an additional purpose of oversampling component that focused on recruiting participants from populations for which there are limited data on health outcomes. And those were often from healthcare provider organizations. So All of Us is an incredible resource, but it's really not designed to be nationally representative. So treating prevalence estimates from the data set as if they represent the US population can lead to some misleading conclusions. Fortunately, using statistical methods to increase the generalizability of estimates from non-probability samples like All of Us has been an active area of work for many years. So most methods use a probability sample as a reference to adjust data from the non-probability sample. And in most approaches, this involves calculating analysis weights for the non-probability sample. There are certainly some other researchers that have developed methods to make All of Us data and prevalence estimates more generalizable to the US population, but these are often in conjunction with some pretty sophisticated methodological advancements. And we found that these methods are really not very readily accessible to most All of Us researchers. So that's a really big gap that we aim to address with this work, to make these methods accessible to anyone on the research workbench. And let me start with the punchline here, because it's not what you might expect. We found that weighting can improve the generalizability of All of Us prevalence estimates, but it doesn't work uniformly across all health conditions. For some conditions, the weighting can actually amplify bias. So we'll explain today how that might happen and how you might want to think about that in your own work. So for our approach, we aim to be completely consistent with the core values and the ethos of All of Us, and to empower all researchers to explore the generalizability of their findings by making these methods completely openly accessible and free. So to achieve this, we developed WOW, W-A-O-U, the R package, and that serves as a toolbox for All of Us researchers to calculate and validate the weights that we're talking about today. WOW is a free open source tool, and it allows researchers to evaluate the generalizability of prevalence estimates from the All of Us data using the framework that we're going to discuss today. In the study, we provide a framework for assessing generalizability by examining 3 case studies. The 3 health outcomes we're going to focus on today to demonstrate different applications of the tool are dementia, type 2 diabetes, and depression. We focus on outcomes derived from the electronic health records because most research on health outcomes in All of Us uses EHR-derived clinical case definitions. And using WOW, we estimated and visualized both the weighted and the unweighted prevalence, compare them to benchmarks to demonstrate the opportunities and potential pitfalls of applying these methods. So the package, the paper, and the tutorial workspace on the researcher workbench are all freely available to you and are intended to work together as a reusable framework to help researchers assess the generalizability of their findings. For the data we're using today and discussing, we used 2 sources. So of course, the All of Us research program and the research workbench data, and then we're using the probability sample from the National Health Interview Survey as our benchmark. We selected the 2023 NHIS as our benchmark because it is the largest nationally representative survey that has similar demographic variables to assist us with the weight construction, and also asks us about the same outcomes that we're going to be looking at. So NHIS has survey questions that directly ask about the lifetime diagnosis for dementia, type 2 diabetes, and depression. And they also provide publicly available micro data to help us with the design weights. The sample size is so large that it's adequate to support subgroup analyses, and you'll see how important that is for this work later. For the all of us data employed here, we use version 8, which is released in early 2025. It has all of the sample sizes that Brian showed you earlier, over 600,000 survey responses, about 400,000 participants with electronic health records. We just want to note that all of us, it's of course a longitudinal cohort study, although the data used here, the EHRs are longitudinal, but the survey data are cross-sectional. And for this analysis specifically, we excluded almost 240,000 participants who are just the folks who did not have electronic health records available, and then an additional 190 participants who were living outside the 50 states or DC, just to match the geographic coverage of the National Health Interview Survey. NHIS is a cross-sectional annual survey drawn from a nationally representative household probability sample. So like I said, that 2023 data, that's from the sample adult interview. And they had a response from about almost 30,000 adults with a response rate of about 47%. And we do use the NHIS survey weights to account for sampling errors of different types. In order to facilitate comparison and benchmarking for this type of work, we need to create a set of auxiliary variables. The auxiliary variables are essentially what we're using, harmonizing across NHIS and all of us. And these are demographic variables for which the weights are constructed based on those. So the actual analysis weights are constructed using the following 10 auxiliary variables: age, race, sex, sexual orientation, health insurance, education, the US region, employment, home ownership, and marital status. So due to the difference in some of the variable formats between NHIS and all of us, we harmonize all of the response levels to have consistent definitions across the two data sets. You can see all of this in detail in the tutorial workspace. The resulting harmonized variables were then imputed using the RMICE package for missing data with a single imputation. For our outcomes, we are, of course, again, looking at those three specific health conditions of dementia, type 2 diabetes, and depression. And in the National Health Interview Survey, these are identified based on self-reported lifetime diagnoses. So specifically, has a doctor ever told you that you have dementia or depression or type 2 diabetes? In all of us, the outcome definitions are based on our validated EHR-based phenotypes, which were derived from prior validation studies. And the prevalence estimates are calculated using any positive cases identified by those algorithms in the numerator. And then the number of participants who agreed to link their EHR data is in the denominator. The three specific phenotype definitions we used, so for dementia, we used Marilyn Ritchie and Josh Denny's phenotype from a 2010 article in the American Journal of Human Genetics. The type 2 diabetes phenotype is based on Pacheco and Thompson's type 2 diabetes mellitus phenotype from the Phenotype Knowledge Base, published in 2012. And for depression, we used Baker's phenotype from a 2020 publication in Neurology, Psychiatry, and Brain Research. So, of course, it's important to note here that NHIS estimates rely entirely on self-reported diagnoses, whereas the all of us estimates are EHR derived. So differences or discrepancies between the two estimate types could, of course, always reflect measurement differences between EHR capture and self-report, rather than true differences in underlying prevalence. But the framework we're showing you today is what really allows you to think about and ascertain all those different sources of bias that go into the different estimates. For the methods here, we compared three methods for weight calculation: inverse probability weighting, or IPW, calibration, and calibrated IPW. All three use the same 10 auxiliary variables that I discussed earlier, so we did expect them to produce similar results. But comparing the three methods serves as a really useful internal validity check. I'll go into a bit more detail on the methods differences in the next slide. But to evaluate performance, we compared estimates from NHIS with the unweighted and the weighted estimates from all of us. So we calculated absolute differences and relative bias, where, let's see if the Y hat A estimate here and the absolute difference in the relative bias calculations are from all of us. And the Y hat B denotes estimates from NHIS. So Mahmoud has a really fun trick for remembering which is which. B is for benchmark, and of course, A is for all of us. So we also examined subgroup-specific estimates by age, sex, and race to assess how weighting using the demographic data influences the prevalence estimates. And all the analyses and visualizations that I'm going to show you today can all be completed entirely within the WOW R package, which of course is freely available for you to download today. So let me quickly walk you through the three weighting methods that we are comparing here today. Inverse probability weighting models. These model the probability of being in all of us versus NHIS. So it basically upweights the underrepresented groups in the all of us, which essentially make the all of us sample look more like the general population after you apply those weights. Calibration weighting adjusts all of us to match the NHIS population totals, and so it doesn't really use any individual level data. It's just using the totals and then back calculating based on the marginal totals by subgroup. And then calibrated IPW combines both approaches. So it starts with the model from the inverse weighting and takes the IPW weights and then also uses the marginal totals to calibrate for added stability. The key differences here really for you are that the IPW uses individual level relationships, the calibration uses population totals, and the calibrated IPW leverages both. So again, because all three methods use the same information, we expected and we did find that they produce very similar results when you do weight the data. Here is just a quick link for you. So in order if you want to check out the WOW documentation, the package implements all three weighting methods I just described, and it provides a complete toolbox for you to evaluate generalizability of your prevalence estimates from the all of us data. And you can follow the framework that we show here. So WOW includes functions for many different options. So it goes all the way from the variable selection, and it assists with the harmonization and data imputation for the missing auxiliary variables. It performs the prevalence estimation with and without the weights, and it also facilitates the subgroup comparisons across the demographics and the visualizations of those, which really help to give insights into what's going on in the data, where the biases are occurring. So all the tables and figures I'm going to show you today were generated using the WOW functions. All right. So while we don't have time to delve into the details of the effects of weighting on all of the demographics that I discussed, I'm just going to quickly summarize the major upweighted categories. So for younger adults, specifically those aged 18 to 39, those are going to receive higher weights because all of us skews older. Males are also upweighted because all of us tends to skew a little female. And then participants in the South region are upweighted since all of us has lower representation from that region of the US. And white participants and those with the less education are also upweighted. And before I walk you through the results, let me just show you how to read these figures or what we're looking for. So the blue purplish circle is always the NHIS benchmark. So you can see it here, and over here. That's the NHIS, kind of our gold standard estimate. That's the target. The red square on these figures is the unweighted all of us estimate, and the green marks are the weighted estimates. So here's an unweighted estimate here, and the green weighted estimates. What we're looking for is whether the green marks move closer to the blue circle than where the red square is. So if weighting is working, we should see that the weighted estimate lands between the unweighted estimate and NHIS, or ideally right on top of the NHIS estimate. Now let's just take a look to see what happens with the three conditions overall. So for dementia, this top left use case up here, the all of us unweighted prevalence is 1.8%, which is higher than the NHIS estimate of 1.1%. But after weighting, the all of us prevalence decreased to 1.3%, which is much closer to the NHIS benchmark. For type 2 diabetes, we saw an even more dramatic improvement. The unweighted all of us prevalence of 12.5% was substantially higher than the NHIS estimate over here of 8.3%. This is the largest absolute difference of the three conditions, and the weighting considerably improved the estimate here. So it gets a lot closer to the NHIS benchmark. Depression, however, tells a very different story, which is very instructive for thinking about these methods. So the unweighted all of us prevalence was 16.6%. You'll see that here. This is actually lower than the NHIS estimate of 19%, which is here. And then when we weighted the data, the all of us prevalence actually declined further to 14.5%. So you can see clearly in this figure that all three weighting methods produced nearly identical results. They're overlapping on the plot, confirming our expectation that using the same auxiliary variables would yield similar performance. So you can see the overlap in just about almost perfect in each figure. So in the next slides, we're just going to be looking at the IPW weighted estimates. But most importantly, as you saw here, while weighting is improving the alignment for dementia and type 2 diabetes, it's actually exacerbating the differences for depression. This sample, or this figure, summarizes kind of the same information, but looks specifically at a measure of relative bias for each condition in the full sample. So it compares the unweighted and weighted estimates, where green is the unweighted estimates and orange is the weighted estimates. So we see here that it's telling the same story. For dementia and type 2 diabetes, the orange boxes are lower, which indicates reduced bias. But for depression, that orange box gets higher, showing the increased bias after weighting. So this is obviously useful to know, but it leaves us with the question of why. So what is driving these results? And maybe most importantly, why are we amplifying bias for depression? How can that happen? This is where we delve into subgroup results, which gives us insight into how these are operating for each demographic subgroup. And you'll recall that these three demographic subgroups are probably some of the most important ones that are used in the weighting process. So for type 2 diabetes, this is a real success story. Looking at age, you see the expected pattern of increasing prevalence with age in both data sets. So the age figure is going to be up here on the top left, sex on the bottom left, and then race on the top right. And the all of us estimates are moving closer to NHIS across all the age groups. There is one notable deviation from this pattern in the 70+ age group, you can see here. But it's largely the same story for race and for sex, that weighting brings the all of us more in line with the benchmarks. So this is really what we want to see when we're weighting and working across these subgroups. Type 2 diabetes is a well-documented chronic condition where the relationship between the demographics and the prevalence is stable and predictable across both data sets. So the demographic weighting is working as intended. For dementia, we see mixed results. So weighting improves the estimates for most of the age groups, as you'll see here. However, the 70+ age group, where dementia is most common, weighting actually increases the bias here. This is really important to note. Because if you were doing a study of dementia and your inclusion criteria for the study or looking at only those age 70 and older, these weighting methods would actually be amplifying the bias overall, and you could see that. So in our view in this framework, dementia kind of falls in the middle. So weighting helps overall, but the demographic adjustment doesn't uniformly correct bias across all the subgroups, and particularly in the most important subgroup for this condition. And to get to the meat of the story, depression reveals a fundamentally different pattern that explains when weighting can actually amplify bias rather than reducing it. So this is our most important finding and take-home message for you all. Let me first explain the key assumption behind weighting here. So we assume that once we adjust for demographics, any remaining differences between all of us and the general population will be minimal. So in other words, weighting assumes that the relationship between the demographics and the outcome is similar in both data sets. But I want to draw your attention to the pattern of depression by age between these two data sets. And that specific assumption is violated. So NHIS shows that peak depression prevalence in young adults up here, around 21% for ages 18 to 39. So, and this also declines with age. And all of us actually shows the opposite, where the lowest prevalence is in these same younger groups at just 11 to 14%, and then increases with age. So here's what happens when we weight is the process upweights those younger participants to make all of us sample look more like the general population. Remember when I told you earlier that all of us skews older, so these specific age groups, 18 to 39-year-olds, were getting upweighted. So, but because the young people in all of us have lower reported depression prevalence based on their electronic health records, while young people in NHIS have a high depression prevalence, upweighting the all of us estimates makes the overall estimate even lower, moving it further away from the NHIS benchmark instead of closer to it. So this demonstrates a really critical limitation, that demographic weighting cannot correct for systemic biases that operate independently of these demographic characteristics. The poor performance for depression here it likely reflects some fundamental differences in how depression is captured in EHRs versus self-report. And then there's probably some age-related things going on here as well, where young people particularly seek mental health care in different settings than older people. But this is really important to know about the data when you're reporting on prevalence in using these electronic health record-derived phenotypes. So what does this mean for you? Most importantly, we want to emphasize that as a general rule, all of us data were never intended for calculating prevalence of diseases or health conditions. Prevalence in all of us should not be assumed to represent the general population. And researchers who do estimate prevalence should note that the estimate is representative of the all of us participant sample only, not the entire US population. Second, no solution is optimal for all research questions. Each researcher should really carefully evaluate how the all of us sample characteristics and the data collection methods might specifically affect your study outcomes and in the target population. Importantly, the effectiveness of the different auxiliary variables in the weight generation model will also vary depending on the demographic characteristics of the populations most and least affected by the condition or the outcome under study. So truly best practice in this regard would include tailoring your weight selection or your auxiliary models and your validation for each research question in consultation with a subject matter expert and a biostatistics expert. Third, the source data type, of course, so for example, here, the survey and EHR differences, in addition to characteristics of a given clinical condition, will affect the likelihood of inclusion in the data set in both directions. So that'll affect the representatives of the results with and without adjustment. The researchers really cannot assume that weighting will improve the generalizability of your findings, but it can give you a lot of insight into why it is not generalizable, or if it is. Fourth, the WOW package can be used to facilitate all of the work described here to give you insights into the sources of bias that might be present for your outcomes. So researchers can assess the appropriateness of using the all of us data to answer different research questions by considering the generalizability of the findings. And finally, we strongly recommend that researchers compare the weighted and the unweighted estimates against other validated external benchmarks when possible. You want to acknowledge the limitations of a non-probability sample and the weighting approaches as well, and exercise particular caution when you're making population-level inferences about conditions that are subject to these pretty complex ascertainment biases, as you've seen here today. So our work opens up several important directions for future research, which we think are really major opportunities for researchers like yourselves, and for the All of Us program more broadly. First, it would be great to examine how modifications to our phenotype definitions affect the prevalence estimation, particularly for conditions that require specialized treatment or resources. So case definitions that depend on expensive diagnostic procedures or specialist care, for example, can introduce systemic bias, because populations with limited healthcare access would be systematically underrepresented in those condition codes. Second, developing gold standard phenotypes that combine electronic health records and survey data is an incredible opportunity that's pretty unique to all of us. The discordance between survey and EHR-based phenotypes will vary across conditions, but understanding these discordances combined with adjusting for differences in the underlying sample could be a really important step towards developing gold standard phenotypes in this data. Third, we need to better understand which types of conditions are most vulnerable to information and other types of bias in all of us. Characterizing the condition-specific vulnerabilities would help us and help guide other research as well when additional validation steps or alternative methods are necessary. Fourth, just from a methodological perspective, future work should also examine the sensitivity of these prevalence estimates to different auxiliary variable models and other calibration data sources. So these models specifically that we're presenting today are dependent on what is in NHIS, for example. But other sources could have been used to calibrate, including census or ACS data, NHANES, or other population-based surveys. And finally, the variance estimation methods do require further development. So you'll notice today that we didn't actually present any confidence intervals around our weighted estimates. And that's because that's still an area of active research. So future research could develop more comprehensive approaches to uncertainty and quantifying that uncertainty that incorporate both the sampling variability and potential bias from unmeasured confounding factors. Thank you all so much for your time and attention today. I'm really hoping that this work helps you think critically about generalizability and your own research when you're using the All of Us data. I want to again emphasize that all of the methods and tools we discussed are freely available for you today. You can access the full manuscript that's available in the American Journal of Epidemiology using that QR code on the left. The R package and all the documentation is available in that middle QR code. And then we have a featured tutorial workspace in the All of Us Research Workbench that includes all of the code we used for this analysis, including the harmonization code, if you want to gain some insight into how that works. And so each of these QR codes will take you directly there. And just want to end with a few thoughts. So, we designed WOW specifically to empower all of you, right? This is for the research community. Not just those with deep statistical expertise. So to evaluate the generalizability of your own research estimates. So I really am hoping that you try it out with your own research questions. And we are happy to take some questions now. I have Tamara Litwin, the senior author on this manuscript, who just has an incredibly deep knowledge of the All of Us data, as well as Mahmoud Elkasabi, our method specialist and the second author on this work here with me today as well. So thank you.
Thank you so much, Barrett. A sign of a great webinar is lots of engagement and interest, and we have a lot of questions that have come in. So I'm going to direct those to those of us on the panel here. If you want to stop sharing, Barrett, we can come back out to
sorry.
That's all good. And I want to open with a question actually for Tamara. You're generally there's a specific question, but I also want to ask a broader one about how we might understand the differences in these different sources of data that we've talked about. Here today, we might think about aspects of all of us recruitment to all of us. EHR data as a phenomenon. Generally. And comparing that to NHIS, how might we understand those differences? And let me ask you the specific one here that came in from an audience member as well. Given that all of us has self-reported outcomes, there's curiosity about how those prevalence estimates that might be derived, as we're talking about here today, compare to NHIS. So just generally, can you talk to us a little bit about the differences as we kind of compare these different elements and think about them as we have in the context of Barrett's discussion today?
Thank you. Yeah, that's two great questions. Maybe I'll take the specific one and then the general one. So in terms of survey data, this particular study did not look at the self-reported data. The main reason for that, well, there are a few reasons, but one of the main reasons for that is that it is less complete. So we have fewer responses to the personal and family health history survey than we have participants with EHR data. I know this question came in before Barrett presented that final slide, but that is something that this team might look at in the future, because we know that that's obviously a huge potential source of additional information, particularly for some of those conditions like depression and other mental health conditions that aren't well represented in the EHR. For the more general question, I would say these are fundamentally very different types of data sources. The NHIS study is meant to be representative of the US population. It is self-reported. Everything is self-reported. So the way in which that information is gathered is directly from the participants in the study, and they are chosen to be like the US, like the US population. All of us is all volunteers, so of course we intentionally did try to over-recruit in certain populations, but fundamentally those participants have said, I would like to be part of a research study, and it's long-term, it's longitudinal. They've signed up in different ways, and they've given us their data in different ways. And in this case, we use the data that was reported by their healthcare providers rather than, well, the demographics came from the participants themselves, and the EHR came from health provider organizations. And we know that that data is not complete, but it is also, it's just coming from a different place. So two tremendously valuable sources of data, and all of us has the additional self-reported data, but fundamentally they're trying to do very different things.
Great. That's an incredibly helpful overview, Tamara. I really appreciate that. Here and talking about ways we can connect and compare, but also understanding the really important differences, I think is crucial. A number of questions have come in with more focused details that they're interested in, and so I'm going to direct those to some of the panelists here, and some of these might take less time to answer, but we can ask these questions directly. Barrett, I'm going to start with a question for you about the ascertainment of type 2 diabetes. The question is whether or not using the EHR, was that done at the all of us baseline, or was that done at lifetime? That was done lifetime as well. Was the question.
Yep, important question, and this relates to Tamara's response as well, because the definitions across both data sets conceptually they are identical. They are both. We're always looking at lifetime prevalence in both cases. Of course, the methods of ascertainment are very different across the two data sources. But yes, we did use, they are conceptualized as lifetime. So at any point in the EHR, whether it was from 2018 or from 1985, if they had that condition, that they were counted in the numerator for that condition. The electronic health records, there's an interesting question here about just generally like how far back the EHR data go for each participant, and that's going to vary a lot by participant and by healthcare provider organization. So theoretically, lifetime, yes. In practice, it depends on when that participant started contributing data to the specific electronic health record that was shared with all of us by the healthcare provider that consented to share the health record. Tamara, is that accurate? Yeah, I'm trying to summarize that as well as I can.
Great. Excellent. Thanks so much, Barrett. We've got a couple of questions here that I'm going to turn to Mahmoud to bring him into the discussion. Barrett, at the end of your talk, you referred a little bit to the issue of confidence intervals. We actually had a question that came in about this, which was what about confidence intervals for the prevalence estimate? But also there was a question, whether or not single imputation will underestimate the variability. Mahmoud, I don't know if you wanted to address or talk about that. I know this is an issue of ongoing research as well, but
Sure. Thank you, Brian. Yeah, I just wanted to start to reiterate that basically the main objective of this study is basically to provide the general framework, and we recognize that actually in each step a better job could have been done in terms of actually using more advanced methods. But our aim is basically to outline the framework and provide a tool for all of us users to be able to implement these procedures. Saying that regarding the imputation, we decided basically to proceed with the single imputation because we wanted, first, we wanted to keep it simple. Second, we didn't have a lot of missing data. So the magnitude of the problem actually convinced us that it's okay to proceed with the single imputation. However, I would like to make a distinction here between actually the imputation of the auxiliary variables and whether it will have any impact on the confidence intervals, because here the issue that Barrett mentioned at the end of the slides about the confidence intervals or various estimation for the study variables. This is a different topic. The single imputation, we did it for the auxiliary variables because we needed like a complete auxiliary variables to be able to use them for the estimation of the inclusion probabilities for the all of us study or data sets. However, the second part is basically the variance estimation for the study variables, the 3 study variables. And as Barrett mentioned, this is like an ongoing topic, which is like the variance estimation from the non-probability samples. And since this is an area under advancement, we felt like we are not confident enough to basically produce confidence intervals for these estimates right now. And we believe this is an area for future research. More research can be done on that. So we didn't want to produce something that we are not confident about. Thank you.
Great. Well, Mahmoud, I want to come back to you with another question here about the WOW package specifically. And the question was whether or not it could be used for regression estimates besides prevalence estimates. And so I'm trying to get a handle on the utility of the package.
Sure. Yeah, one of the capabilities of the package is that it actually produces a weighted estimates and a weight variable at the same time. So by releasing this weight variable, users can use the weights for any types of analysis they are interested in. It can be like a simple, like proportion means estimates, or it can be regression estimation or any more advanced type of analysis they are interested in.
Okay. Well, and because it's related, let me ask this one additional WOW question that came in. The question was whether or not the package operates or works by being applied directly to all of its data without requiring a secondary data source such as NHIS to use it. I'm not sure if you want to describe or discuss that question a bit further, Mahmoud. Yeah.
Sure. I mean, all the methods that we use and the other methods as well for these methods to work for estimation from non-probability sums, you should have a benchmark. And by benchmark, we mean like another reliable source of data. It can be actually a micro data like the NHIS as we used, or it can be a population aggregates or totals from census or from any other source, or even from another reliable survey. So the WOW wouldn't just work as long as you have to provide like a benchmark. This benchmark can be NHIS or other reliable sources as well. In the current version, we provide the NHIS 2023. It is attached with the package, so user can basically call it from the package itself. But they also have the flexibility to define any other benchmarks from any other resources. But yeah, they have to have a benchmark.
Well, and just to also orient people that may be entirely new to thinking about the workbench. I mean, there still is going to be the requirement that they're working within the workbench environment, and so this isn't somehow that you're taking data offline and moving in that way. And it's probably important to emphasize that, I think. But that this is a tool or a package that can be used within that environment that you're essentially importing. I guess
yeah. I mean, it's also worth mentioning that the WOW package is basically it is developed to be used within the workbench. However, for users who are interested in use it for like educational purposes or for illustrations or to get used to it, they can use it externally also, but on simulated data of all of us. It's not on a fake data that's released with the package. But for actual estimation from all of us, they have to use it within the workbench.
Yeah. Excellent. Barrett, I'm going to come back to you with another clarification question here. This was about household income and whether or not that was included in the IPW calibration in terms of weighting. So if you talk a little bit about that as a factor.
Yeah, we looked at using, so there were two variables that we explored using for the auxiliary set that we did not end up using. One of them was the household income, of course, and the other one was disability status. We found that disability status was essentially just we weren't able to harmonize the response categories between how it was asked in NHIS and all of us, so it's not used. And for household income, it was missing for about 20% of, I believe, the all of us respondents. And so we just felt that that was beyond the threshold of what we were comfortable with, the going back to Mahmoud's, what we discussed with the single imputation method. We just felt like there was a little bit too much missing data there. So we didn't feel like it would actually contribute much to the auxiliary variable model.
Great. Okay.
But it could be used. And if you want to do multiple imputation to impute it, that's totally possible.
Yeah, and that's helpful to know the flexibility there. Great. Tamara, I want to come back to you with a question that's come in. And the question, as it was posed, is does the data include any variables addressing QOL and quality of life or functioning, through self-report or using standardized assessment measures? Is there how might we comment on that, or does that relate to other work that you might want to point the audience member to?
Yes. Again, a good question. So Barrett just addressed why disability wasn't included in the model in this particular project, but all of us does have data on life functioning. We use the 6-question American Community Survey scale for assessing disability. We also do have a quality of life question in the overall health survey. And I would encourage the questioner to also look through the entire social determinants of health survey, which has a lot of related variables about things like quality of life and sort of additional variables that might impact some of these conditions. And again, it will depend on the condition, but for your study, it might be useful. So those are the places that I would suggest looking. And the All of Us Survey Explorer has all of the surveys in full, including the source material. And the researchallofus.org website also has a searchable database of all the variables, and you don't need to be logged into the workbench to access that. It's public.
Great. Excellent. I want to come back, Mahmoud, to a question here, which, generally speaking, one of the you've provided a tool. There are ways to potentially use this. It's not a universal, magic tool. There are some cautions that have to be, kept in mind here. And I'm wondering, I think some folks are potentially interested in knowing whether or not your application of weighting may be causing more trouble than it's worth. What warning signs might suggest that if your application of weighting, as we saw in one application here, that it might actually be worsening bias. What are some things that users ought to look out for in using this approach that perhaps might suggest some additional caution?
Sure, thank you. So yeah, I would be reiterating what was mentioned in the slides by Barrett. So basically, since all these methods are model-based methods, which means that basically you should have a model in mind. And by model here, I'm talking more about the auxiliary variables. So you should have you should use like specific auxiliary variables that are common between the probability and the non-probability sample. So the non-probability here is all of us, and the probability is the benchmark survey. So to what extent the adjustment method would work, it really depends on whether these probability or auxiliary variables are is able actually to predict the the probability of the belonging to the all of us, and at the same time to able to predict the study variables. So uh, the more relationship between the auxiliary variables and the study variables and the belonging to the all of us, the more successful these methods are. So going back to your question about the warning signs, we always should have a benchmark. We should always do like the relative bias, calculate relative bias, check the relative bias, the absolute differences, see whether there are any improvement when it comes to the relative bias or not. Um, check the weight values to see whether there are values that are very high. This might be a warning sign. Check several methods and see whether there are like big jumps between the methods. This can be a warning sign as well. So yeah, I would just follow the same approach outlined in the paper. And this would give you an idea about how to deal with it. But yeah, it's very important to have a reliable source or benchmark or idea about the prevalence of this what you are measuring.
Great.
Yeah.
Thanks,
Can I just
Mahmoud.
add to that briefly?
Sure.
Just in addition to what Mahmoud said, I would say that it's always worth exploring this issue of generalizability for a health condition, because it even if it's just a sensitivity analysis in your research paper, this strengthens your work by a lot. It shows that you've really explored and thought about the condition that you're presenting on and what might be going into biases and ascertainment. There are biases in every single data set we work with. There's no separating our research from that. The key issue is not that we have bias, it's how we're dealing with it, how we're acknowledging it and exploring it. So, for the key example here that we use for depression, every subject matter expert will probably agree that, yeah, it's more prevalent in younger folks. So what is what is going on in that EHR data? And so you can begin to really explore and understand the literature around, yeah, there are reasons for differential reporting this in the EHRs for younger people for this condition. So that makes sense as well. But it all just contributes to the overall research system and the rigor of the work, in my opinion.
Great.
Thanks, Barrett. And can I just, sorry, now we have
Yeah,
like
well, I
30
was going to give
seconds.
you last word here, and then we'll wrap up. Yeah.
Thanks. Yeah, I think I would say we understand that every researcher who's coming into all of us wants their findings to be useful beyond all of us, right? There's a reason that we care so much about generalizability, and there's a reason that researchers are always trying to expand their conclusions to the wider or a wider population. So I just want to completely reiterate what both Barrett and Mahmoud have said, that this is an issue that we know about and we want you all researchers to know about and to be thinking about, and for every study to sort of truly ask in what ways is and isn't this generalizable, and what statistical methods can I use to help me make that conclusion and to help create generalizability where possible, and where can you not. In some cases it's just not a good idea. So for that depression example, perhaps that's not the right place, and you should be looking at all of us survey data, for example. So that's the kind of takeaway that I think we hope that everyone will get from both this webinar and the paper.
Yeah, that's really helpful. And even recognition of limitations of generalizability doesn't mean that it's not worth pursuing certain studies, with data in different ways too. So this has all been incredibly helpful. We're really lucky to have the three of you on here and to talk about your work with your colleague in developing all these resources. I'm just going to put a quick note up on the screen as folks roll off here. We do have a couple of additional webinars upcoming. If you enjoyed this and you would want to join us again, we'd really welcome that. You'll see a couple of QR codes on the screen. On March 12th, we have an introduction to phenotyping in all of us. And on April 20th, we have a webinar on planning your data analysis on the All of Us Researcher Workbench with special considerations for accessing and applying data from the American Indian and Alaska Native population. So if those topics are of interest, please do scan the QR code, register for either of those. And I also hope that everybody can just join me in thanking our great panelists and presenter here today very much. Thank you for spending the time with us, and we'll see you next time.